त्यांचा शोध. तुला डोंगरे मॅडम शोधत पण मॅडम मी तिघे मध्ये सरांनी सांगितलं तू काय करत तुझा तुला जॉईन व्हावं
त्याच्यावर क्लिक करते जॉइन मीटिंग पासवर्ड टाकते रॉंग पासवर्ड
ही तर जॉईन झाली आता
हो ती जॉईन झाली मग एक मिनिट
तू आधीच्या लिंकवर ना जॉईन त्या दिवशीच्या
ते मेल आला त्याच्यावरती
Good morning, ma'am. Good morning, Arta ma'am. Good morning, ma'am. Ashish.
गुड मॉर्निंग सर. गुड मॉर्निंग सर.
Good morning, Ashish.
हा गुड मॉर्निंग सर. दीपिका मॅडमची वाट बघतोय.
Okay.
दिसत नाही अजून.
डॉक्टर राजेश.
नमस्कार मॅम. कशा आहात?
हॅलो आशिष.
कॅन्सल करून परत जॉईन कॅन्सल करून मीटिंग मध्ये परत मीटिंग
क्या करूं? लीव करके फिर ज्वाइन वाटते हेडफोन्स बरोबर नाही आहेत. तुझ्याकडे आहेत का? तुझ्याकडे आहेत आशिष?
हो आहे.
तुला लागणार आहेत का?
काही सांगता नाही वेळ द्यायला काही प्रॉब्लेम नाही.
ट्रायल घेऊन नको हिमोग्लोबिन करणे.
हॅलो
केला होता.
सर गुड मॉर्निंग. गोंदडेकर सर.
गुड मॉर्निंग शिवांगी मॅम.
गुड मॉर्निंग सर. वेलकम.
अरे आपलंच काम आहे.
काय सर?
म्हटलं आपणच आहे ना, त्यामुळे काय प्रॉब्लेम.
हा दीपिका मॅडम अजून जॉईन नाही झाल्या.
नाही ठीक आहे ना काही
होतील सर.
नाही काही.
Good morning, Dr. Deepika.
Good morning, ma'am. Good morning, sir.
Good morning, ma'am.
Good morning, sir.
Good morning, Dr. Deepika.
Good morning, ma'am.
तिला म्हणा इकडे आणा. सगळं घेऊन नाही, मी अजून एंट्री नाही दिली आहे.
अजून कोणाला
तुम्ही कुठे आहे? पण दिसत नाही.
मी झूम मध्ये केली आहे.
हा, आल्या आल्या आल्या.
Good morning, Rachna, ma'am.
गुड मॉर्निंग. गुड मॉर्निंग. राजेश आहे का?
बोलावलं इथे बसून.
अरे वा.
Yes, sir.
आणि ते
गुड
सर्टिफिकेट
मॉर्निंग डॉक्टर दीपिका, डॉक्टर राजेश.
Good morning, ma'am.
Thank you, ma'am.
Good morning, everyone.
Chalo. Good morning, Ram.
मला
Dr.
ते
Ram.
काम करायचं.
Hello everyone.
Good morning, Rarities.
Good morning, sir.
ते ऍडमिट आउट कुठे असते?
सर्टिफिकेट सांगायचे.
तुझं तरी पण तू ट्राय कर, कारण की मला इकडे नाही हे सगळं सारखं सांभाळताना
ती लॅपटॉप मधनं करते.
करते.
सरच्या सर्टिफिकेट.
Start, Rakshita.
एकदम मोठ्या याच्यात आहे ना.
तिथे आहे.
Rakshita.
Yes ma'am, 1 second.
मोठ्या आहे का? जुनच आहे का? म्हणजे याच्यात खूप problems आहेत. Okay, ठीक आहे.
Got to start?
हा.
Hello, a very good morning to one and all. On behalf of Oral and Maxillofacial Pathology, VSTM Dental College and Research Center, I, Dr. Rahul Sorbe, Senior Lecturer, welcome you all to the CDE 2022. The concept of the webinar is directed towards providing future oral pathologists and everyone with an educational feast to enrich their knowledge and explore something that is unknown. We at the department have organized this event with the hope of providing just the same. I humbly request our head of the department, Dr. Alka Dive Madam, to address this virtual gathering.
Very good morning to everyone. Respected Dean Dr. Usha Radke Madam, Dr. Rajesh Gondalekar, Dean, Professor and Head Department of Oral Pathology, VYWS Dental College, Amravati. Today's guest speaker, Dr. Deepika Mishra, Additional Professor, Department of Oral Pathology and Microbiology, AIMS, Delhi. Vice Dean and PG Director, Dr. S.R. Shenoy. Dr. Mukta Motwani, Vice Dean, Clinical, and Professor and Head, Department of Oral Medicine and Radiology. Respected senior faculty members who are my mentors, all head of the departments, my colleagues, and postgraduate students. On behalf of Department of Oral Pathology and Microbiology, VSTM Dental College and Research Center, I welcome you all for this webinar. The rare lesions of the oral cavity will be discussed by Dr. Deepika Mishra, and definitely we all get benefited. My heartfelt thanks to Dr. Deepika Mishra for accepting our invitation as a guest speaker to share the rarities of the oral pathology. I am thankful to Dr. Rajesh Gondalekar for being with us today as a moderator in spite of his busy schedule. Thank you, Dr. Radke Madam, for your inspiration and motivation always. Thanks to Dr. Shenoy for his kind cooperation always. Thank you, Dr. Mukta Motwani, for your support. Thanks to all the participants for their participation in the webinar. And I would like to thank all the staff members of the department, Dr. Shubhangi, Dr. Ashish, Dr. Rohit, Dr. Rakshata, and Dr. Neena for their contribution towards the success of this program. Wish you all a Merry Christmas and Happy New Year. Thank you once again. Over to you, Rakshata.
Thank you so much, madam. I now request our Vice Dean and PG Director, Dr. S.R. Shenoy, sir, to kindly say a few words. Please, sir.
Thank you, Rakshita. Good morning, everybody. Dr. Rajesh Gondalekar, Dean VYWS and Member of Management Council, MEHS. Speaker for today's function, Dr. Deepika Mishra. Our Dean Madam, Dr. Mukta, Dr. Alka, and all those who have joined here. I would like to congratulate all of you for hosting this program on rarities in maxillofacial pathology. And I'm sure that everybody who is listening to this program would be immensely benefited by this webinar. The dark clouds of COVID always has got some silver lining in the sense that we could host webinars since the last 2 years. And hopefully, not for COVID, but we would continue to carry on the webinars in the days to come, because it has reduced the distances. There's nothing such as being very far away, because anybody from anywhere across the globe can host a program, can become a speaker, and this would be benefiting for everyone. So this particular webinar, which is happening after a short hiatus, would be definitely something that everybody stands to benefit from. And my congratulations to the Department of Oral Pathology led by Dr. Alka Dive. And I profusely thank the speaker, Dr. Deepika Mishra, and the dignitaries who have joined, Dr. Gondalekar, for coming on to this webinar. Thank you so much and all the best. And I'm going to listen to this on YouTube.
Thank you.
Yes, sir. Thank you so much, sir, for your encouraging words. I now request our respected Dean, Dr. Radke Madam, to enlighten us with her words.
Good morning, everyone. Today's guest speaker, Dr. Deepika Mishra, moderator for today's session, Dr. Rajesh Gondalekar, Dean, VYWS Dental College, and Dr. S.R. Shenoy, our Vice Dean, PG Director, Dr. Mukta Motwani, Vice Dean Clinical, Dr. Alka Dive, Head of the Department, all senior faculty members, and all delegates, those who are watching this webinar on a digital platform. My special welcome to Dr. Deepika, Dr. Rajesh, and all are welcome to this webinar. Our college and the Department of Oral Pathology has the great legacy of having a great pathologist like Dr. A.T. BBG sir, who was Dean and Head of the Department, who has developed our oral pathology department and also contributed in development of our VSPM Dental College. Also, we have now Dr. Hazare sir as an adjunct professor and our head of the department, Dr. Alka Divya Madam. It is always a matter of pride for me that when our colleagues appreciates the diagnosis of our oral pathologists in our oral pathology department. So congratulations, Dr. Divya Madam, for developing the department and conducting this today's webinar. I am happy to know that near about 200 delegates have been registered for today's webinar. Though many colleges are not having the PG admission this year and last year also, but 200 is a great number. So thanks for taking efforts for this webinar, Madam and your team. We all know that basic principle of science is to always think of the simplest explanation for a condition. It is always a dilemma for a clinician to distinguish between a common case and the rare case. Many times diagnosis depends on the clinicians. So I believe that there should be a good or great coordination between clinician and oral pathologist always. So with this, I'm sure that Dr. Deepika will give justice to the topic that is rarities in oral pathology, and our all delegates will be benefited with today's webinar. So thank you very much, and once again welcome you all. Thank you. Over to Dr. Rakshata.
Thank you, madam.
Thank you so much, ma'am, for your inspiring words. Means a lot to us. I now request Dr. Rohit Moril, sir,
Recording in progress.
to introduce our today's moderator, Dr. Rajesh Gondarekar, sir, Dean, Professor, and Head, Department of Oral Pathology and Microbiology, VYWS Dental College, Amravati.
Hello.
Yes, sir.
Yeah. Very good morning to all of you. Today we have with us a very dynamic personality in the field of dentistry, Dr. Rajesh Gondarekar, sir. Dr. Rajesh Gondarekar, sir, is acting dean and also professor and HOD in the Department of Oral Pathology and Microbiology, VYWS Dental College and Hospital, Amravati. Sir has done his BDS in 1991 and MDS in 1994 in the Department of Oral Pathology from the Nagpur University. He has also done PG Diploma in Forensic Odontology in 2017. He has completed his fellowship in clinical trial from the Delaware University. He has also D.Pharm degree from the Nagpur University. He has been on the various prestigious posts, member Management Council MUHS Nashik, member Academic Council MUHS Nashik, Chairman Board of Studies Dental Preclinical MUHS Nashik, member Standing Committee Maharashtra University of Health Science Nashik. He has also held various posts like Vice President in the Indian Dental Association Maharashtra State Branch in the year 2017 and 18. He has also been a treasurer in IDA Maharashtra branch in 2005 to 8. I welcome Gondarekar sir and also request sir to please moderate the session. Over to you, sir.
Thank you, Rohit. Good morning, everyone. Respected Radke Madam, Dean, VSPM Dental College and Hospital, Dental College, Nagpur. Respected Shenoy sir, Vice Dean, PG Director, VSPM Dental College, Nagpur. Respected Motwani Madam, Vice Dean Clinical, VSPM Dental College, Nagpur. Respected Dr. Alka Divya Madam, Professor and Head, Department of Oral Pathology and Microbiology, VSPM Dental College, Nagpur. Senior teachers, students, and people participating for today's webinar. I am happy to introduce Dr. Deepika Mishra. She is Additional Professor of Department of Oral Pathology and Microbiology, All India Institute of Medical Sciences, New Delhi. She is a renowned academician and won many awards. I'll just shorten her biodata because it's quite large and we are more interested in the talk which she is doing. So I'm just being short in her introduction. She is a renowned academician and won many awards for paper and poster presentation in various conferences. Her research interests include diagnostics in oral cancer and potentially malignant disorders. Her significant contribution to research include developing a detection device for oral cancer along with IIT Delhi. She is a research faculty for oral cancer screening at WHO SEER Open online course. Madam will be enlightening us with rarities in oral and maxillofacial pathology. I like Madam. I'll hand over the stage to Madam. Thank you.
Thank you so much, sir, for your kind words. I'll just share my screen. And I would also like to request, like Madam, if there is any sort of disruption, please you can stop me in the middle and maybe just let me know, because this is one of the side effects of the online platform. So at the outset, I would like to thank the organizers of BSPM Dental College and Research Center, Nagpur, and especially Alka Deve ma'am for giving me this opportunity, and the entire team for taking this very good initiative of having a seminar on such a interesting topic. Even I learned a lot during the entire process of this talk. So hope so I'll do some justice to this particular topic. So today we'll be talking about the rarities in oral pathology. I basically come from the Institute of All India Institute of Medical Sciences, and this is the place where I work, and this is a center for dental education research where we have our oral pathology department. So basically, I want to start with a nice saying that desire changes nothing, decision changes something, but determination changes everything. So with this, a very good morning to all of you. And I am sure that we definitely, we all who have joined here are determined to basically understand all the rare pathologies and are trying to, we are sort of determined to make some sort of changes in our field as well by setting a benchmark in our diagnosis. So I would just start from the cases. So our cases would comprise from different spectrum. So it would be really nice if any of the questions you can always put up in the chat box. We'll address them at the end, and it would be a very nice thing to have your opinion also as we go case wise. So this is a 49-year-old female presented with a recurrent swelling over right side of the face, as we can see in the radiology. So here she had a swelling since 6 months. The patient also gives a history of a lesion in the same site in 2013, for which she got operated at that time. But she didn't have any records, so we don't have any clue what exactly that lesion turned out to be. So what we saw in the histology was, a biphasic pattern. So many of the times we just get a very brief history. That's one of the, a part of our oral pathology practice. Sometimes we get to see the patient. Sometimes we just get to see just the histology, just the slides or the radiology. But we should always make an attempt to get the clinical findings and to get to see the patients so that we can correlate, because that really makes a lot of difference. So what we saw in this histology was basically a biphasic pattern of presentation of the cells, and there was a collagenous stroma which was separating these nodules and the nests of tumor cells. When we saw under the high bar, there were more of a clearing of the cells with some eccentric nuclei and clear to faint cytoplasm. And these are all separated by the hyalinized collagenous stroma. In very few areas, when we try to focus in the entire slide, there was certain peripheral columnar differentiation, and you can see some nuclear vectorization, but those were only seen in few of the areas, as we can see. There were also intermixed some small dark unvacuolated cells with hyperchromatic nuclei and slightly scant to eosinophilic cytoplasm. And then there were certain hyperchromatic cells, hyperchromatic epithelial nests and clusters of these cells. These are the high power of this particular case. So based on this histology, we made the differential of calcifying epithelial ontogenic tumor. So the most common one with the intraosseous location is a clear cell variant. And then the clear cell ontogenic carcinoma. So whenever we see a clear cell intraosseous tumor, that's one of the differential which comes to our mind. Do not have as such any other ontogenic tumor which can show a lot of clear cell changes other than like now the recent classification of WHO states that even they have removed the classification in ameloblastoma. So any tumor which
Hello. Deepika ma'am, you are not audible.
मैडम का नेट काम नहीं कर रहा होगा.
Recording in progress.
Hello. Good morning, Hazare sir.
Sir, good morning, sir. Hazare sir, good morning, very good morning, and welcome to this webinar.
Good morning, Hazare sir. Welcome to the webinar, sir.
There is a madam has some technical.
Okay, no problem. So, welcome to Barpande sir also. Welcome to
Sir, join झाले.
Hazare sir also.
Sir, good morning, sir. Barpande sir, and welcome to the webinar.
Sir, परत sir.
Good morning.
Sir, good morning, sir. Sir, Barpande sir, welcome to the webinar.
Good morning, Alka. I
Sir,
think it is already started. So
sir,
go ahead,
good
please.
Sir, Hazare sir, good morning, sir, and welcome to the webinar, sir. Madam ला काहीतरी दीपिकाला problem. Thank you, sir.
I'm listening. First case.
Thank you, sir. Thank you,
Volume
Hazare sir
नव्हतं
and
म्हणून मी
Barpande sir, for being with us today. Deepika madam join.
Yes, she is joined.
Okay.
Yes, ma'am. I'm really sorry. I don't know.
No,
There was some
sorry.
connection issues. Okay. I think so. You have to allow me for the participant screen sharing.
Yes, ma'am. I think I have to make you again co-host. Make you co-host.
Good morning, sir.
Yes, ma'am. Now you can share.
Okay. So are you able to see my screen?
Yes.
Okay. So sorry for the mild disruption. So basically on that, I'll just go back.
Ma'am, if you don't mind, there is very low voice. So if it is possible for you, so can you speak slightly loudly?
Yeah. Okay.
Okay. Thank you. Thank you.
So basically so I'm just going back slightly, just, as we are just talking about the differentials. So as we can see in these, in the histology, they were more of a hyperchromatic nuclei with some, small dark looking cells, as well as most of the cells predominantly showed clearing of the cytoplasm. Okay. And based on that, we had a differential of calcifying epithelial ontogenic tumor, the clear cell variant, the clear cell ontogenic carcinoma, the intraosseous mucoepidermoid carcinoma, especially the clear cell variant, and the clear cell carcinoma. Now, the other rare ones could be metastatic clear cell carcinoma, like the renal cell carcinoma, breast carcinoma, and the clear cell melanoma. So is my voice audible? Is it okay? Okay, so when we went for the IHC to confirm our diagnosis, the CK56 was positive in most of the tumor cells. CK7 was predominantly positive in all these tumor cells, and P40 was strong and diffuse nuclear. It showed strong and diffuse nuclear positivity for these tumor cells. Again, P63. So P40 is just an isoform of P63. So basically, I prefer more of a P40 than P63, but even P63 was positive for these tumor cells. Pan-CK, definitely as was predicted, because it looks like a epithelial tumor. So it was positive for these cells. Now, PAS was non-contributory, and we could not appreciate any mucinous material. This was done just to confirm if it could be a clear cell variant of mucoepidermoid carcinoma. So it was negative. SMA, it was positive. It was internally positive for the blood vessels, but the tumor cells were completely negative. And then Vimentin was also not very contributory. It was positive as a reactive in the stromal tissue. HMB45 just it's a marker, more specific marker for the melanoma. It turned out to be negative for these tumor cells, so it ruled out melanoma. So when we came to the differential diagnosis, so the tumors which primarily arise in the jaw bones, with or without mucosal involvement, because when we saw this lesion, it was not showing any mucosal involvement, but we considered these as a differential, like the clear cell CEOT and the eye intraosseous mucoepidermal carcinoma. So in the clear cell CEOT, you get to see more of a squamoid cells with eosinophilic cytoplasm and intracellular bridges, calcifications, which were completely absent in this present case. You can also confirm it through EWSR1 gene, which is completely lacking in CEOT. Now, intraosseous mucoepidermal carcinoma, they have greater tendency for cyst formation, and they do show some sort of mucinous cells, which or some mucinous material, which was also a negative for PAS. But though CK7 was positive, which also was going towards the salivary gland pathology, but CK7 can also be positive for any ontogenic lesion as well. So when we talk about mucoepidermal carcinoma, we should see those typical squamoid and intermediate looking cells, which were also not so typical in this present case. So yes, the metastasis, though they could be real, but they could be rare, but they show more of a vascularity, and they show mostly solid growth pattern or crowded nested pattern, which was not so prominent in the present case. The nuclei are more atypical, and the dual stroma which we were seeing in this particular case was lacking in metastatic renal cell carcinoma. And they never express P63, which is almost always expressed in clear cell ontogenic carcinoma and clear cell carcinoma. So based on the intraosseous location, P40 and P63 positivity, we signed it out as a clear cell ontogenic carcinoma. So these lesions are quite rare, and the clear cells, they are similar to glycogen-rich pre-secretory amyloblasts. Mostly they show the molecular rearrangements of EWSR1 gene, which is also, consistent with the clear cell carcinoma of salivary glands. So there is absolutely no marker which can differentiate between a clear cell carcinoma of salivary gland and clear cell ontogenic carcinoma. So there has been a hypothesis that they could represent intraosseous clear cell carcinoma. Now, these clear cell ontogenic carcinoma, they're mostly seen in more than 50 years in mandible. They mainly present with pain or lower lip paresthesia in the patients. Radiologically, they could be unilocular or multilocular with ill-defined margins. Mostly they show three patterns. They could be biphasic, showing nests of clear cells with polygonal epithelial cells, which are more eosinophilic, as was in our present case. Sometimes they could be just monophasic, like only clear cells with separated by the hyalinized tissue could be seen, or they could be ameloblastoma, like with the peripheral cells showing palisading pattern. Mostly these tumors, they do not show much of a pleomorphism, mitosis, or areas of necrosis. And because they are aggressive, so they require radical surgery. Metastasis in the regional lymph nodes is quite less, approximately 20 to 25%. So coming to our next case, which is a 42-year-old male who presented with a buccolingual swelling in the right mandible. This patient presented with a multilocular radiolucency, as you can see in this radiology, in the right mandible, with some sort of pathological fracture. On histology, it showed more of islands, you can see islands and sheets, some of the follicles and cords of ontogenic epithelium, which are infiltrating within the collagenous stroma. So the entire stroma is all collagenous and shows more of a hyalinization. Now, when we saw in the high power, they showed more of a central hypercellular areas, and there were peripheral hyperchromatic palisaded basal cell layer. in the high part, there were more of a monomorphic spindle-shaped cells, which were showing some of the swirling pattern in many areas. And then there were areas which showed more of a, subnuclear vacuolization and palisading of the hyperchromatic cells, which are mostly columnar and basal cells. And there was central ovoid to spindle-shaped cells showing a squamous differentiation in few areas. Now, the central or the pleomorphic and spindle-shaped cells were also hyperchromatic. And then there was some intercellular keratin formation focal area. Predominantly, the stroma, these tumor sheets showed a lot of vascular, a lot of vascularization and hemorrhagic areas. And there were abundant apoptosis and mitosis. So based on these, we made a differential of plexiform and glioblastoma, which can show increased mitosis. But yes, atypia was going more towards amyloblastic carcinoma. Then amyloblastic fibrosarcoma is also kept as a differential, though the presence of amyloblastic islands surrounded by spindle-shaped fibroblasts or photoantigenic mesenchyme, they can also exhibit pleomorphism and atypia. But yes, even in a particular case, it showed more of ontogenic, epithelium, which was also showing a lot of atypical features. Then ontogenic sarcomas. Now, the ontogenic sarcomas can also show presence of odontogenic hard tissue like dentinoid and cementoid, which was completely absent in our present case. Other differentials which we have kept, though quite rare, are the carcinosarcomas and fibrosarcomas. Mostly, all these tumors are vimentin positive, whereas amyloblastic carcinoma is one such lesion which is vimentin negative. When we went ahead and did a proliferative index, Ki was slightly high. It was approximately 20%, and mostly in the basal layer. So considering focally high mitotic activity and high cellularity and infiltrative pattern, we signed it out as a spindle cell variant of amyloblastic carcinoma. This spindle cell variant of amyloblastic carcinoma is basically a variant of amyloblastic carcinoma, which can show, proliferative areas as well as spindle population that resembles fibrosarcoma, but lacks histological features of amyloblastic fibrosarcoma. So on the basis of this differential, there has been certain histologic criteria which has been laid down, like ameloblast, a carcinoma with amyloblastic differentiation, or a sarcomatoid cell population intimately associated with the epithelial component. So both these criteria needs to be fulfilled to call it as a SCAC. So in short, they are the carcinomatous and sarcomatoid components. They should be intimately associated to be called as a spindle cell variant of amyloblastic carcinoma. So when we talk about WHO 2017, this was the classification which has been laid down for the malignant as well as benign tumors, and in that the amyloblastic carcinoma has been included. Now in the recent WHO 2022 also has laid down the similar features. They have not changed many of the features of amyloblastic carcinoma. The important point which they've stressed is that over-diagnosis should be avoided, and the malignant features like increased nuclear cytoplasmic ratio, pleomorphism, nuclear hyperchromatism, abnormal mitosis, along with increased mitosis and vascular and perineural invasion, and areas of necrosis should be given a very important, they are the important criteria to be diagnosed as amyloblastic carcinoma. And mitotic activity alone should not be interpreted as a feature of malignancy, as they are more marked in maxillary than mandibular ameloblastomas. So they do not, just on the basis of mitotic activity, it should not indicate malignancy. Coming to the third case, which is also slightly similar line, is a 56-year-old female who reported with a chief complaint of swelling in the right lower posterior region. And as we can see in the radiology, was a osteolytic radiolucency in the right mandibular region with certain irregular and erosive borders. In histology, it showed more of infiltrating tumor islands and nests and clusters of tumor hyperchromatic tumor cells in the collagenized stroma. So when we saw the hyper, these tumor islands are predominantly basaloid, which showed central cystic degeneration. And these basaloid-looking cells, they displayed hyperchromatic nuclei with minimal cytoplasm. Many of these tumor islands at the periphery, they displayed nuclear subnuclear vacuolization, certain reversal of polarity. Basilar palisading was also seen in few of the areas, but predominantly the peripheral layer are columnar to cuboidal. And then there were a lot of apoptosis and increased necrosis. Most of these central-looking cells, they showed squamoid differentiation. They were squamous looking with abundant eosinophilic cytoplasm and vesicular nuclei. And a lot of nuclear pleomorphism could also be appreciated. Now, these squamoid-looking cells, they also displayed clearing of the cytoplasm in many of the areas, that we can see at this on the left corner. So based on that, we made the differential of clear cell odontogenic carcinoma. Again, the clear cell CEOT always remains the differential. The pleomorphism is one aspect which goes against the clear cell CEOT, but yes, because they can show sometimes hyperchromatism, they are always kept as one of the differential. Then clear cell MEC, because of the basaloid-looking tumor cells, we kept basaloid squamous cell carcinoma as one of the differential. And yes, ameloblastic carcinoma would remain because of its intraosseous location. And rarely there could be neuroendocrine carcinoma or nut carcinoma, which can also present in a similar fashion. So, of course, there was the overlying epithelium, and there was no component of conventional invasive squamous cell carcinoma, and overlying epithelium is completely normal. So, the basaloid squamous cell carcinoma is completely ruled out. We should get to see some conventional form of squamous cell carcinoma like keratin pearl or a lot of diskeratosis. So all those features were lacking. Then clear cell odontogenic carcinoma, they predominantly they do not show much of a basal cell palisading pattern. So that was also sort of ruled out, and they show predominantly of clear cell changes. Unlike our case, where only focal area was showing clear cell changes. Then CEOT, yes, it shows typical polygonal cells with prominent cell junctions, which was absent in our case. Then we went ahead and did certain IHC, and our case was negative for CK7, just ruling out any salivary gland pathology like intraosseous MEC. Then synaptophysin and chromogranin we did to rule out neuroendocrine differentiation, which was negative, and not one to rule out nut carcinoma, which can sometimes display, squamoid differentiation. So our present case was positive of P40 and CK56, highlighting more of a epithelial differentiation, and KI index was quite high, approximately reaching up to 80%. So this is just to highlight how these tumor cells were all positive. They showed a very high KI proliferative index. So the presence of basal cell layer with palisaded nuclei showing reversal of polarity in focal area. Then subepithelial hyalinization and cytological atypia in most of the areas, and increased mitosis and very high Ki67 index. We sign it out as a ameloblastic carcinoma again. And ameloblastic carcinoma, though they are uncommon in aggressive epithelial ontogenic tumor, they can exhibit histological features of conventional ameloblastoma, accompanied by the cytological features of malignancy. Mostly they are common in 3rd to 4th decade. In 2005, ameloblastic carcinomas, they were divided into primary, secondary, and intraosseous and peripheral type. And 17 and even 22, they have kept them under, they have classified these tumors under ameloblastic carcinomas. So the maximum Ki67 index till date has been reported as 53% with nuclear immunopositivity in both peripheral and central cells, though the present case showed a very high Ki index of 78%. So what does it indicate? It indicates more of an invasive aggressiveness, invasive nature of the ameloblasttic carcinoma, and also can predict the metastatic nature of these rare entities. Now, because of its rarities, it is important to combine the histological, architectural, and cytomorphological features with KI index to confirm our diagnosis, and only the increased mitosis should not define these entities. However, it indicates their aggressive proliferative nature. So we should be careful and should try to, assess the Ki67 index for most of these cases. So the next case is a 46-year-old male who presented with a chief complaint of pain and numbness on the left side of the lower face for 4 months. The patient presented with an irregular osteolytic lesion with cortical destruction in the left body of mandible. The patient had a history of open transabdominal adrenalectomy for adrenocortical carcinoma. But when we saw the CT scan, it showed enhancing soft tissue lesion in the left body of mandible, causing erosion of the mandibular cortices with extension into the floor of the mouth, and also you can appreciate the soft tissue extension. When we saw the histology, it more predominantly a cellular stroma, which displayed more of a highly atypical cells with abundant eosinophilic granular cytoplasm, and we can appreciate a lot of hyperchromatic and hyperchromatic nuclei, and more than these most of these cells, they displayed more of a granularity in their cytoplasm, though few of the less than 20% of the tumor cells also displayed some clear to faint eosinophilic cytoplasm. So when we saw the hyper, most of these cells are oval to polygonal shaped and displaying the granular cytoplasm, and a lot of anaplasia which could be appreciated in this hyper feature, like the hyperchromatism, increased NC ratio. It's almost 3 times the size of the normal nucleus. Then a lot of pleomorphism, and even in one hyper field, we can see more than 3 to 4 mitosis per hyper field. There were numerous tumor giant cells and bizarre looking nuclei, which showed clear to faint cytoplasm, as we can see in the lower right side, to eosinophilic cytoplasm. So what were the differential? Because it was an intraosseous location, we thought of osteosarcoma as the first differential, followed by chondrosarcoma, then the intraosseous salivary gland tumor, like the oncocytic variant of central mucophthalmic carcinoma. Undifferentiated pleomorphic sarcoma can also, but it's a diagnosis mostly of exclusion. And the rare ones like the melanoma and metastatic lesion are also considered. So Ki67 were approximately 20%, and it showed focal cytoplasmic positivity for synaptophysin and inhibin. For rest of the markers like PAN, CK, CK56, CK818, Vimantin, SMA, CD68, we did to investigate the line of differentiation, and focal positivity was seen in almost all except SMA. So immunonegativity for SMA and focal positivity for CD68, it suggested more of a tumor infiltrating histiocytes. And SAD-B2, SN-RED, melanine, and CK7 all were negative, which excluded intraosseous malignancies like, SAD-B2 excluded osteosarcomas, negative SN-RED excluded chondrosarcomas, and chondrosarcomas and melanomas. Then CK7 and negativity, it ruled out any salivary gland malignancy. So based on that, we went back, because we have almost ruled out all of them. So we went back to the radiology, and we again saw that the patient had undergone open transabdominal adrenalectomy. Okay, so we searched back into the previous logical records, and to our surprise, when we looked into the slides of the the adrenalectomy specimen, it showed a similar kind of features with predominance of oncocytic looking cells, and which were more. It also showed us sheets of round to polygonal shaped cells, and mostly they were also areas of necrosis and increased mitosis in those cells, and they were positive for even pan-CK, which was negative in the metastatic lesion. and were negative for all the other markers, like our case. So we gave it like a metastatic adrenal cortical carcinoma. We got the patient, the whole FDG PET CT scan for the patient, and it showed uptake and highlighted the osteolytic lesions with large soft tissue component in the left mandibular body, sacrum, and hypodense lesion even in the left lobe of liver. So patient had metastasis on all the 3 sites. So we have to be really careful with our history. Yes. So what are these metastases to the oral cavity? They are quite unusual and mostly associated with widespread disease and has a poorer prognosis. So in 25% of cases, it is the first warning sign of an unknown malignancy at a remote site. So as was in our case, patient just came with a slight pain in the jaw. None of us actually, sort of suspected that it could be a metastasis. Then the jaw bones, particularly mandible, are the most affected site, followed by soft tissues, frequently gingiva. And they can present with varied signs and symptoms, which can create a diagnostic dilemma, thus delay my diagnosis. One very important clue which, our patient presented was a paresthesia of the mandible. So paresthesia of the mandible in the absence of specific etiology should raise the possibility of metastatic sign, as it implies invasion into the bone and involvement of inferior alveolar nerve. Now, the metastatic deposits from adrenocortical carcinoma are very rare, and though ACC is the most well-known primary cancer in the adrenal gland, with an incidence of approximately 0.5 to 2 cases per million. In addition to conventional ACC, there are 3 histologic variants according to WHO: oncocytic, myxoid, and sarcomatoid variant. The oncocytic variant, which was the present case, is the most common variant, and there's no gender predilection, and the mean age is approximately 48. Predominantly, they show round to polygonal tumor cells with abundant eosinophilic granular cytoplasm, and they have a better prognosis than conventional myxoid and sarcomatoid variant. The distant metastasis is reported in 13% of cases, as was in our case, and the 5-year survival rate is approximately 47%. So coming to the next case, is a 14-year-old girl who reported with a pain and swelling in the right lower jaw. And as we can appreciate, a large expansile lesion in the right mandible with a intraoral pedunculated soft tissue overgrowth. And the radiology, it showed that a well-defined multilocular lesion, which showed a heterogeneous solid cystic lesion in the right mandibular body with cortical breach. The histology, it showed a hypercellular area with overlying parakeratotic normal looking stratified squamous epithelium. These hypercellular areas, it showed mostly the sheets of ovoid to spindle-shaped cells. And there were numerous multinucleated giant cells. You can see there were numerous multinucleated giant cells with irregular contours, which were exhibiting vesicular nuclei. There were also sheets of atypical ovoid to spindle-shaped cells with enlarged vesicular nuclei and irregular contours. And there were marked nuclear and cellular pleomorphism. So again, it was an introitious location. So osteosarcoma would always remain the first differential. Then because of the, we could not appreciate any of the osteoid in the given sections. And because of the lot of multinucleated giant cells, we kept malignant giant cell tumor of bone as one of the differential, though it is quite rare in the jaw bones. Then myofibroblastic sarcoma. Now we have a low-grade myofibroblastic sarcoma, which can also present intraosseously. And also we have now rhabdomyosarcoma with TFCP2 rearrangement also being reported in the intraosseous location, especially the mandible. So those are also, they also have a myofibroblastic differentiation, so they are also kept as a differential. Then again, UPS, which is again a diagnosis of exclusion, which was earlier termed as malignant fibrous histiocytic sarcomas. Now they are all termed as undifferentiated pleomorphic sarcoma. And then because of a lot of vascularity, we kept angiosarcoma. And yes, chondrosarcoma, though we could not appreciate any chondroid matrix, but because of the, atrocious location and a lot of giant cells. We kept chondrosarcoma as one of the differential, very rare. SAD-B2 was positive in many of the tumor cells, but not all. CD68 was positive in many of those histiocytic or multinucleated giant cells, looking cells, again signifying more towards a monocytic monocyte macrophage lineage. Then galectin-1, which is again a marker for osteoblastic lineage, was also positive in those tumor cells, which were positive for SAD-B2 also. Now H3, F3 were positive. It's mostly a marker done for giant cell tumor of bone, was also positive in few areas. For the other markers like SMA, it was negative, so ruling out all the myofibroblastic sarcomas or rhabdomyosarcomas. We also did myogen D1, which was also myoD1 and myogen, which was negative for this present case, just without a rhabdomyosarcoma with TFCP2 rearrangement. Then CD31 and 34 was ruling out angiosarcoma. And again, S100 was negative for those tumor cells, again excluding chondrosarcomas. So CD68 being positive in multinucleated giant cells, and H3F3A positivity, it raised the suspicion of giant cell tumor of bone. However, SAD-B2 and galectin-1, which suggested the osteogenic lineage, we favor the diagnosis of osteosarcoma, giant cell rich over the giant cell tumor of bone. Of course, the younger age also favored the diagnosis of osteosarcoma over GCTB. So what are these giant cell rich osteosarcomas? Osteosarcomas, we know that they are the common primary bone tumor that occurs rarely in head and neck region. But GCRO is a very rare type of osteosarcoma and accounts for only 3% of all osteosarcomas, with jaws being the rarest site. Histologically, they show presence of atypical cells with a minimal or scanty tumor osteoid deposition along with the multinucleated giant cells, which makes GCRO challenging to differentiate from GCTB and undifferentiated pleomorphic sarcoma. Now, recognition of osteoid matrix is a very important determinant for the osteosarcoma. But wherever we get a limited malignant osteoid, definitely the IHC, especially SAD-B2 or galectin-1, which are marker for osteoblastic lineage, can be very helpful. Here we should remember that these are the markers for the osteoblastic lineage. So they could be even positive for the benign tumors. Like for example, SAD-B2 and galectin-1, they could be positive for even the benign tumors of bone. So they do not indicate malignancy, but yes, they definitely indicate that has a osteoblastic lineage. So we did a lot of literature review for the GCRO, and mostly they show predilection for mandible. 6 cases have been reported in mandible and 3 in maxilla, followed by the other sites like parotid region and labial mucosa. Mostly they can present as metastasis, or they could present as the primary site could be the mandible. So present case was basically third reported case of GCRO, which is primarily originating in the mandible, because most of the cases they occur as metastasis. So they primarily present at different sites and then they report in the mandible. So yes, we could diagnose this. So coming to our next case. So this is a young patient with a swelling in the mandibular labial vestibule since 2 years. And as we see in MR imaging, it showed hyperintense lesion causing scalloping of the outer cortex of the mandible. And when we saw the ultrasonography, it showed well-defined echogenic lesion in the subcutaneous plane in the right side of the chin, and it displayed bunch of the vessels with predominantly low resistance arterial flow and Doppler imaging. Now, when we saw in the histology, it was predominantly a highly cellular stroma, and those tumor cells were shown infiltrating into the muscles, and they were all variably sized blood vessels, which can see throughout the stroma. This just to show you a high power how these tumor cells were infiltrating within the muscles. There were also few dilated blood vessels, which some engorged eosinophilic material as well as RBCs. present adjacent to the cellular areas of the spindle cells. These tumor cells were also shown infiltrating into the adipose tissue. Now, the cellular areas, they showed both mixed population of spindle-shaped cells with vesicular and hyperchromatic nuclei, as well as epithelioid-looking cells. So we can see that the black arrow shows more of spindle-shaped cells. Mostly, some of them arranged in a swelling pattern, and the epithelioid tumor cells with enlarged vesicular nuclei and eosinophilic cytoplasm. Now, these cellular areas, this is just to highlight, the spindle-shaped tumor cells with variably sized blood vessels, and they were all immunopositive for CD31 and CD34 also. So, based on the IHC marker as well as the cellularity and the variably sized blood vessels, we signed it out as a spindle cell hemangioma. It was quite a classical diagnosis, but the main thing is for this particular lesion is that they are quite rare to occur in the oral cavity. They are mostly slow growing tumor which present in the subcutaneous as dermal or subcutaneous nodules, and they mainly affects the distal extremities. So many of these cases, they report to the dermapathology people or dermatologists. So this was also presenting in the chin region, and we were fortunate enough to get to see this case. Now, the superficial lesions, they appear bluish, while the deeper lesions appear skin color due to the difference in the thickness of skin over the lesion. Now, spindle cell hemangioma, they mostly occur in the middle age, but may occur at any age, and they are clinically as solitary or multiple subcutaneous nodules. And as was in our case, it was also showing us swelling in the labial vestibule. So many of those cases, they report to the oral pathologists, because when they report to the oral surgeons, of course, they get the investigations done, followed by the biopsy. Now, microscopically, it is important to differentiate these hemangiomas from the other vascular tumors like the Kaposi sarcomas and angiosarcomas, because these are the malignant lesions, and yes, they require a different treatment altogether. So SCH, they mostly show the presence of phleboliths, which are nothing but the calcifications in the cavernous vessels, and the plump endothelial cells, which can differentiate it histologically from Kaposi sarcoma. Though in our case, we could not appreciate any areas which could highlight phleboliths. Then the slit-like spaces, they're mostly predominantly seen in Kaposi sarcoma, but are not a prominent feature in SCH. And then there are other ancillary methods like IHC, which can help in differentiating it from Kaposi sarcoma, like HHV8 positivity is found mostly in Kaposi sarcoma, whereas they're absent in these spindle cell hemangiomas. So the foremost criteria are the lack of infiltrative growth pattern, significant nucleotopia, high mitotic rate, and atypical mitotic figures. Those are mostly seen in angiosarcomas and are completely absent in SCH. So yes, we could rule out all these sarcomas from these benign-looking aggressive tumors. Then IHC can help in just deducing the origin of the tumor cells, because they would be positive for all these vascular tumors like CD31 and 34, which are the markers. So along with these, the factor 8 and SMA are also present in SCH and can help in diagnosis. So coming to our next case. So this is quite an interesting case. It's a very young child, 2-year-old male, who presented with a swelling in the left zygoma region for 2 months and presents with expansile lytic lesion involving the body of the left zygoma and anterior zygomatic arch with cortical destruction. When we saw the histology, it was just a moderately collagenous stroma showing sheets of cells, looked more like inflammatory looking cells. And there was certain brown pigmentation, and then there were few of the multinucleated giant cells. Yes, there were a lot of multinucleated giant cells, then sheets of histiocytes, and they were all masked by intense inflammatory infiltrate. So many of the times, even in our inflammatory pathology, we get to see this kind of picture. They just to show you high power of those multinucleated giant cells, which shows some of these cells showed more than 20 nuclei. And these MNG, these multinucleated giant cells are of irregular shape. And then there were sheets of histiocytes with round to oval shaped vesicular nuclei and forming cytoplasm. Many of them had, prominent nuclei and as many as 20 nuclei per cell. And then there was certain brown pigmentation, along with emperipolysis, which is nothing but the phagocytosis of lymphocytes and erythrocytes within the cells. So based on that, we made a differential of giant cell granuloma, which is most common in the central location, followed by aneurysmal bone cyst, which can also show certain types of giant, multinucleated giant cells with a lot of hemorrhagic areas, and then the histiocytic disorders. Now, the giant cells, they were mostly of irregular shape and showed emperipolysis and brown pigment within cells. So that was one of our major clue. Then there were absence of high cellular areas with osteoclast type giant cells with the eosinophilic cytoplasm and large sinusoidal vascular spaces and hemorrhagic areas that excluded the giant cell granulomas and aneurysmal bone cyst. Now, these CD68 was positive in most of these, multinucleated giant cells as well as histiocytes. And also the SN was positive in many of these histiocytes looking cells. CD1A, just to, rule out, the neurogenic origin of these, or Langerhans origin of these multinucleated giant cells, which was negative. So based on that, we gave the diagnosis of Rosai-Dorfman disease, extranodal type. So these are the rare histiocytic disorders, which usually present as a painless lymph node adenopathy in adolescents and young adults. And they most commonly involve the orbit, eyelid, and upper respiratory tract. Very rarely they involve the bone, less than 10% of cases. And the primary intraosseous RDDs, they mostly affect the metaphysis of long bones and very rarely craniofacial skeleton. So 22% of these extranodal are reported in head and neck, predominantly in nasal cavity and paranasal sinuses, and are quite frequent in pediatric population. Microscopically, yes, they show sheets of large histiocytes, and emperipolysis is the hallmark of the disease, but is not specific to this RDDs. Now, the treatment, because they are mostly localized and asymptomatic, so they are treated with surgical excision with a proper follow-up. The symptomatic lesions, they undergo surgical excision. Chemotherapy, the role of chemotherapy is still not clear, but yes, there have been few cases which show that they respond well. Then sporadic RDDs, they are usually self-limited and has a good outcome with spontaneous remission in up to 50% of cases. So these are quite rare entities, but yes, we need to remember these, especially these RDDs, because we many a times just confuse them and with the benign looking inflammatory pathologies. And yes, their treatment and the follow-up is very different from the other entities. So coming to our next case, I would also like to request Divya ma'am, if I'm exceeding the time, just let me know. I can stop in the middle. Okay.
No, you can continue. Your cases are very interesting, and no problem. You can continue, Dr. Deepika.
Okay, thank you. So this is our next case. This is a 62-year-old female who reported with a proliferative nodular growth in the anterior maxilla since 5 months. There was an osteolytic lesion, as you can see in the right anterior maxilla. So there's an osteolytic lesion, and when we saw the CT scan, CCT, there's a soft tissue extension, and there's a soft tissue extension outside the bone. And when we saw the histology, there were sheets and nests of tumor cells within the hyalinized stroma, and the stroma showed a lot of vascularity. So it's more of a fibrovascular stroma with certain, slit-like vascular channels and a lot of hemorrhagic areas. Here, I would also like to just highlight that the parakeratotic surface epithelium is quite normal. Now, when we went to, this is just a hyper, we could also appreciate certain brown-looking pigment. This is just to highlight the brown-looking melanin pigment, and most of these cells are spindled tumor cells, arranged in interlacing fascicles in few areas. Most of these cells are spindled to round-looking cells with hyperchromatic nuclei, and we try to see that the nucleoli is not so prominent, and they have a very indistinct border. We could not appreciate any, cytoplasmic borders or junctions around these cells. So based on that, the first differential which we should think of when we encounter any spindle cell lesion in the oral cavity, the first differential is always a spindle cell variant of squamous cell carcinoma. Because of the melanin pigment which we could see in our case, we kept melanoma as one of the differential. And then because of a lot of vascularity and slit-like channels, we kept vascular tumors. We subjected the case for SOX10 and S100, and it showed, so SOX10 I always prefer over S100 because it shows a very high nuclear positivity over S100, which is mostly cytoplasmic and quite diffuse, and sometimes I do not find it as a very reliable marker. So SOX10 showed a high nuclear positivity as well as S100. HMB45 was focally immunopositive in many of these tumor cells. Ki67 was again approximately 10%. PAN-CK, P40, CD31, all of them were negative. So completely ruling out oral squamous cell carcinoma, which was our first differential. So it should be positive for PAN-CK and P40. So it was negative. Then CD31 was negative, ruling out, vascular tumors. SOX10 and S100, whenever they show strong and diffuse positivity, we should always think about melanoma rather than, malignant peripheral nerve sheath tumor, which shows patchy positivity. And whereas the melanomas, they show strong diffuse ones. Now, HMB45, which is more of a specific marker, so they show patchy positivity. In the present case, showed patchy positivity. So I would like to highlight that SOX10 and S100 are mostly the sensitive markers for melanoma, whereas the HMB45 and Melan-A and the other ones are mostly the specific markers. So there could be certain cases which could be completely negative for HMB45, which could be melanomas. So based on that, we sign it out as a spindle cell melanoma. These entities, they occur mostly in soft tissues, either as a metastasis or as the extension of a locally advanced melanomas. The lymph node metastasis with extracapsular extension into soft tissue is an extremely common presentation. So we should always look and check for lymph nodes for these particular cases. Now, the primary tumor may show either spindle or epithelioid morphology, and they show strong and diffuse positivity for S100 and SOX10. And Melan-A and HMB45 are rarely useful, being expressed only in less than 10% of our cases. Histologically, sometimes we can confuse spindle cell melanomas with desmoplastic melanomas because both of them, they are characterized by atypical spindle and malignant melanocytes. Now, the desmoplastic melanomas, the cells are mixed with the ropey and dense collagen fibrils. They are also common in head and neck region, and they clinically present with a flat or nodular scar-like lesion. They're usually not well circumscribed, and the malignant cells, they track along the pre-existing structures such as skin appendages or nerves. That's an example, the neurotropic melanoma. So because of this specific growth pattern, they are responsible for higher rate of local recurrences compared to other subtypes. Whereas when we talk about the spindle cell melanoma, they're frequently amelanotic, as was our case, which showed only focal melanin pigmentation. They can occur anywhere on the body and presents typically with a widespread metastatic disease. Because of the spindle cell morphology, they are mostly confused with the mesenchymal or neural tumors like MP and ST. That's why, we need to also understand how to interpret the SOX10 for these particular entities. Then synovial sarcomas and leiomyosarcomas, they can resemble these entities. So whenever we have a spindle cell morphology, we do rule out synovial sarcomas, especially we perform CD99 to rule them out, and also the location, mostly which are the oropharyngeal areas. And the leiomyosarcomas and undifferentiated pleomorphic sarcomas can also be ruled out with your immunohistochemistry, which are mostly, they show positive for, myofibroblastic markers. So coming to our next case, these are the cases which I've presented in our national conference. So could be a slight repetition for the people who have attended a conference, but I thought that most of our participants could have missed it. So I thought that maybe let me just share them. So this is a 32-year-old male who presented with a well-defined multilocular radiolucency from the maxillary central incisor to second premolar. The patient had a history of extraction of teeth and he had underwent a surgical removal of associated soft tissue. Again, with no histological examination was done, so we do not have any clue what was. Based on the radiology and the clinical presentation, we thought of it as a benign odontogenic lesion. In histology, we saw mostly the predominantly, highly cellular stroma, and what we could see was normal-looking, parakeratotic epithelium overlying, as well as there was certain myxoid degeneration in the tumor areas in the underlying stroma. When we saw the high power of those cellular areas, we could appreciate two population of cells. So the first one is mostly the the spindle-looking cells, which was showing certain storiform pattern in few areas, and then the other population showed more of a epithelioid-looking cells. So again, this is just to show you the high power of the spindle-looking cells, which were showing more of a nuclear pleomorphism and cytological atypia, whereas the other population showed more of a epithelioid morphology. They were more like a with open-faced nuclei and fascicular nuclei and prominent nucleoli as well. We could appreciate a lot of mitotic figures in both the population, the spindle as well as the epithelioid looking cells. So this is just to show that the mitotic figures were quite high in both the population of cells. So these epithelioid looking cells, they had more of a eosinophilic cytoplasm with large vesicular nuclei, coarse chromatin and conspicuous nucleoli. And then there were certain myxoid degenerations. Now, this is just to highlight that there were certain areas of necrosis which could be appreciated in these particular tumor areas. And a lot of inflammatory infiltrate interspersed within these tumor cells. So based on that, we made a differential again. Because of the spindle cell morphology, we kept spindle cell carcinoma or spindle cell squamous cell carcinoma as a first differential, followed by the leiomyosarcoma or the low-grade myofibroblastic sarcoma. Now, the low-grade fibromyxoid sarcoma, because of the myxoid degeneration, which we could see, followed by epithelioid myxofibrosarcoma because of the epithelioid-looking cells. And yes, because and it was intraosseous in location, we kept odontogenic carcinosarcoma as one of the rare differential. Now, spindle cell squamous cell carcinoma should have dysplastic epithelium and well-defined squamous component or invasive front, which were and they almost always shows absence of myxoid stroma, so they were ruled out. Then coming to the leiomyosarcoma, they can show certain epithelioid morphology, but the myxoid changes, they could also be sometimes present, but they are mostly positive for at least one of the marker like Desmin SMA or Eschkal-Desmond, which is seen in almost 100% of cases. So they were completely negative for our present case. Then the low-grade myofibroblastic sarcoma mostly presents in tongue and gingiva, but they can be intraosseous in location. And they typically show skeletal muscle infiltration and fibromatosis-like morphology. They lack epithelioid cells and shows positivity for myofibroblastic different markers like SNA and other markers like Desmin calponin, so which were negative for our case. And again, they are negative for the epithelial markers and SN, right? Coming to the low-grade fibromyxoid sarcoma, they mostly present with alternating fibrous and myxoid areas, and they show branching curvilinear vessels, and they're positive for EMA and NUC4, and they're mostly common in the proximal extremities and trunk. So this kind of morphology is completely lacking. The alternating fibers and myxoid areas were completely lacking, and they were, they mostly show bland-looking stellate cells. Rarely, epithelioid myxofibrosarcoma can also be present in head and neck, so they are rare. And the epithelioid variant, it shows small cohesive clusters in the myxoid areas, but they mostly present as a myxoid stroma predominantly with multinodular growth and with incomplete fibrous septa in between. Again, they also show some prominent curvilinear thin walled blood vessels with perivascular condensation of tumor cells, which was also absent. So all these typical features, all these lesions were also ruled out based on histology. Then odontogenic carcinosarcoma, they should almost always show odontogenic epithelium showing malignant features, which was not present in our case. The present case, when we subjected them for the immunohistochemistry, it showed positivity. The epithelioid-looking cells were positive for pan-CK. SMA was focally positive, and they were, slightly positive for Vimentin as well as 100, which was not very contributory. But then Ki67 was approximately 22%. And almost all the tumor cells were immunopositive for ALK. And the ALK showed typical cytoplasmic positivity with perinuclear accentuation. So we again made a differential of ALK positive lesions, where an inflammatory myofibroblastic tumor with malignant transformation, which is called as epithelioid inflammatory myofibroblastic sarcoma, can also show this positivity. So we kept that as differential. The intraosseous rhabdomyosarcoma with TFCP2 rearrangement, they show myogenin and MyoD1 positivity along with tadpole and strap cells. So it was negative in our case. Then sarcomatoid variant of anaplastic large cell lymphoma should be positive for CD30. So the present case, it showed, P53 showed wild type staining pattern, and INI1 expression was retained. So it was also ruled out as SMARCB1 deficient carcinomas. Then they were negative for Desmin, CD30, myogenin, CD34, and SIB2. So thus ruling out, just confirming that we have sort of ruled out all the osteosarcomas, angiosarcomas or vascular tumors. Myogenin and Desmin also ruled out the rhabdomyosarcomas. We further performed FISH, which showed copy number gain without any break apart signal, just to confirm, our aims. So the present case was a 32-year-old male with osteolytic lesion with irregular margin, showing round 2 epithelioid tumor cells in inflamed collagenous myxoid stroma, and there were increased mitosis, areas of necrosis and high index, KI index, and immunophenotypic features, along with the ALK1 cytoplasmic positivity with perinuclear accentuation. And though it was positive for SMA, so I would just like to highlight that, sometimes it could be a weak marker and can show positivity. So we again have to sort of correlate with histology. Then pan-CK and EMA were positive for epithelioid-looking cells, whereas the tumor cells were negative for CD30, Desmin, 34, and STAT6. So we signed it out as a epithelioid inflammatory myofibroblastic sarcoma. Now it is a variant of IMT. So now inflammatory myofibroblastic tumor, they are the rare neoplasm of intermediate biological potential with local aggressive tumor, and they have a tendency to recur and can show rare malignant transformation. They mostly show in abdominal soft tissue and rarely head and neck. The intraosseous are quite rare, and the mandible is more common than maxilla. Just to show that when we talk about inflammatory myofibroblastic tumor, they show myofibroblastic spindle cells with inflammatory infiltrate of plasma cells, lymphocytes, and eosinophils. And there could be 3 basic patterns, like the myxoid vascular pattern, which shows more of a myxoid and vascular areas along with inflammation. Then there could be compact fascicular spindle pattern, which showed more of a spindle cells intermingled with inflammation, and then less of a cellular pattern. These are all different variants of IMT. Now, IMS is a rare aggressive variant of IMT with high recurrence and mostly seen in children and adolescents. And intra-abdominal location is mostly, reported, and no case till date has been reported for the nathing bones. So IMS shows again more of a round epithelioid tumor cells with scattered information, and they show a typical expression of ALK, which is mostly perinuclear positivity, perinuclear cytoplasmic positivity to nuclear positivity. So just to compare IMT with IMS show more of anaplasia and nuclear atypia compared to the IMT, which are more of a bland-looking spindle cells. Now, these IMS show more different ALK fusion proteins, which are identified. They can be, RAN-BP2 ALK rearrangement, or they could be RRBP1 ALK fusion, which could, correlate with the different IHC expression, which are seen in these cases. Now, treatment are mostly surgical resection, and post-op chemo and radiotherapy is of limited value in preventing recurrence. These cases definitely have a poorer prognosis. The case of IMT in maxilla with sarcomatous changes have been reported with epithelioid morphology, but to the best, this is the first case of IMS which is occurring in the maxilla. So that's why I thought I would share this case. Coming to our last case, I will just be very short in this. It is a 4-year-old male who presented with a, yes ma'am. So this is with a swelling in the right lower back tooth region. And we saw in the radiology, there was certain impacted tooth which was present along with the radiolucent lesion. And this is what we got was an impacted tooth along with the cystic capsule and a lot of some brownish looking tumor tissue. On histology, we could appreciate some keratinized, non-keratinized epithelium and a lot of luminal proliferation of columnar cells. So there were a lot of solid cellular sheets of tumor cells, which showed mostly the polygonal or angular in shape with abundant cytoplasm, which were mostly eosinophilic and showed granularity in the cells. There were also certain mucinous, mucinous differentiation few of the cells, but predominantly it showed granular eosinophilic cytoplasm with few cells showing hyperchromatic enlarged nuclei, increased mitosis, and few tumor giant cells, and prominent nucleoli. Then some of the cords of elliptical shaped tumor cells with a stalked appearance could also be seen. Yes, we kept a differential of COT, granular cell ameloblastoma, which should show more of ameloblastic islands with granular cell changes in the center, which was not seen in our case. COT, we did not appreciate any calcification and, those polygonal looking cells with prominent junctions, we could not appreciate those areas. Granular ontogenic cyst, because of the cystic epithelium, but yes, it lacked all those, Kaplan et al. Criteria. Then there could be certain oncocytic lesions which we thought of, like the oncocytic hyperplasia, oncocytomas, oncocytic carcinoma, which are mostly seen in more elderly age group. Ours was just a 2-year-old young child. And the metastases, which are always kept as a differential for these unique looking cells. We still went and did congruent to rule out any amyloid for COT, which was negative. CK7 was positive in focal area for highlighting the mucinous cells. And CK5-6 and panskemotiva anema was positive, highlighting the epithelial origin of these cells. MUC5AC, which was more towards which is a sort of marker, specific marker for mucophthalmic carcinoma, is positive. AVPAS was though non-contributory. And most of these tumor cells showed positivity for nuclear positivity for P40, which was strong and diffuse. So yes, the P40 played a very important role, in sort of ruling out all the other entities like oncocytoma, oncocytic sarcoma, carcinoma, or oncocytic lesions, which shows mostly the peripheral staining, whereas this particular case showed strong diffuse, highlighting that it could be an oncocytic variant of mucophthalmic carcinoma. So that's what we diagnosed it as, with underlying dentigerous cyst. We subjected this case for NAML2 translocation on fish, which was negative. Primary intraosseous MEC, which are quite rare, they mostly arise from the dentigerous cyst, as we all know, and shows a predilection for mandible and females. Like mucophthalmic carcinomas, these intraosseous also shows squamoid mucin-producing intermediate type cells, along with cystic and solid growth patterns, and they can be of oncocytic clear cell sclerosing variant. So the present case, it was the mucicarmin in past was not so contributory, but many of those cases they do and they are quite helpful, especially in resource limited settings. So those are the first stains which we perform along with the other IHC panel like the P63 and PANSEQ. And yes, wherever the resources are available, we should subject these cases for MAML to gene fusions. So to sum up, I just talked sort of covered up a diverse group of lesions, which also reflect that there's a complex development of dental structures. So in the oral cavity, we get to see a lot of mucosal lesions as well as ontogenic lesions as well. Many of the neuroendocrine tumors can also, or the sinonasal tumors can also, sort of present in or extend till the maxillary region. So we can encounter such rare entities. So these entities are important to know so that we always have some sort of differentials to think about, and we sort of rule out all these differential diagnoses before jumping out onto a particular entity. And here I would also like to sort of state that the greatest value of having good people around is not what you get from them, but the better person you become just because of them. So that's the power of association. So always surround yourself with a lot of good teachers who pull you up, and good friends and colleagues with whom you can associate and get to a good arrive at a right diagnosis. So for these particular entities also, I was not alone who actually diagnosed these cases. There was an entire team. There were my teachers, Professor Alkakale, Seema Madam, and a lot of teacher Hazari sir, who have actually helped me in diagnosing many of these cases. My senior residents who have been teaching me continuously, Dr. Kiran Jodh, especially who helped in she is the one who has actually helped in collecting all these cases and made this presentation. Dr. Vivek and Dr. Varun, now we have a faculty with us. Then our surgery colleagues who are very helpful in sharing their clinical and ecological data in patients, because of whom we could get the entire information and we can go back and get the entire history. Then our pathology and radiology colleagues, especially Dr. Achal Kakkar, Dr. Asit, and Dr. Iyer, who was very helpful in helping us in diagnosing these rare entities. So these rare entities should never be diagnosed in silos. You should always come up. You should discuss these cases with your colleagues so that you should not miss out. Again, the radiology colleagues like Dr. Ashu and Dr. Smitha, who has been very helpful in giving us, whenever we find a problem, especially in terms of benign versus malignant, especially the case of RDD, rhizodophamin disease, where they gave us the first clue that could be a histiocytic disorder. So with that, I would also like to welcome you all for our second AIMS Oral Pathology Symposium, which is going to be held on 27th and 28th January. And again, we'll be highlighting a lot of different pathologies, rare ones. And we are fortunate to have speakers from University of Florida, Dr. Indranil Bhattacharya, Dr. Kamboj from PJ Rohtak. We all are very well versed. Our head and neck pathology experts, Dr. Kakkar and Dr. Farooq, who is an expert in IGIB for the molecular techniques. So along with the clinical pathological conference, which would be, we are also hosting a e-poster competition. And this, we are also conducting a fish workshop. So we welcome you all to AIMS. And though the hands-on is sort of over, we have few of the seats left for the demo. So all of you are welcome to AIMS Delhi, and thank you so much for your patient listening.
Thank you so much, ma'am. Am I audible? Hello.
Yes, ma'am.
Thank you so much, ma'am, for broadening our horizons. It was a phenomenal presentation with beautiful cases. I hope every one of us have got something that actually I start in the starting have mentioned that we are exploring something that is unknown, and that is truly the best part that has been come true today. I would now like to request Dr. Alka Dibe Madam to hand over the certificate to Dr. Deepika Mishra Ma'am as a token of gratitude and appreciation.
Thank you, Dr. Deepika, for your wonderful presentation of the cases and rare lesions. Really, we are benefited a lot with your presentation, and kindly accept this certificate of gratitude from all of us.
Thank you, ma'am. Thank you so much.
Thank you.
Anyone in the participants want to ask any queries to the speaker can unmute themselves and can ask the queries, or can also put in the chat box. Any question from the participants? Okay, I'll now request again Dr. Alka Dibe ma'am to kindly hand over the certificate to Dr. Rajesh Gondarekar sir as a token of gratitude. Okay, sir is not there, I think.
Okay, thank you, Dr. Rajesh. Once again. Okay, he's not there.
Yeah. Okay, all right. Thank you, ma'am, and thank you, everyone. I now request Dr. Shubhangi Khandekar, ma'am, professor, to propose the vote of thanks.
Thank you, Rakshita. Am I audible?
Yes.
Yeah. So I'm presenting the vote of thanks. Yes, gratitude is the attitude that takes you to your altitude. So on behalf of the Department of Oral and Maxillofacial Pathology, I, Dr. Shubhangi Khandekar Bagre, takes this opportunity to extend my heartiest and sincere thanks to our guest speaker, Dr. Deepika Mishra. Thank you, ma'am, for such a wonderful slide seminar. Indeed, it was a feast of rarities in the oral region. I express my heartfelt gratitude to Dr. Rajesh Gondarekar sir, Dean, Professor and Head Oral Pathology Department, VYWS Dental College, Amravati, for moderating this session. Thank you, sir, for taking out time from your busy schedule and gracing this event. My sincere thanks to our beloved Dean, Dr. Usha Rarke, ma'am, our dynamic Vice Dean, Dr. Ramakrishna Shinoy, sir, our very enthusiastic Vice Dean Clinical, Dr. Mukta Motwani, ma'am, for their gracious presence, support, and cooperation for this event. I extend my gratitude to our Head of Department, Dr. Alka Dive, ma'am, for her immense dedication, support, and helping us out whenever and wherever possible. A special mention and deep sense of gratitude to dignitaries, faculties, and PG students and others who are not present here in this event but still were a part of it through a special way of Zoom and YouTube live platform. Without you all registering, this program would not have been a success. I would also like to acknowledge the untiring efforts and enthusiasm of our staff members, Dr. Ashish Budare, Dr. Rohit Mohril, Dr. Rakshita Sorte, and Dr. Neena Wankede. I express my gratitude to our management for technical help and support. Lastly, I thank each and everyone towards the success of this program. Thank you once again and have a nice day.
Thank you so much, ma'am. I now declare the program has been concluded, and I thank all the virtual guests for the participation. These certificates will be mailed to the registered participants. Thank you. Wish you all a Merry Christmas and a Happy New Year. Thank you.
Thank you, Dr. Deepika, once again, and Dr. Rajesh and all the participants. Thank you very much. Thanks a lot.
Thank you, ma'am. Thank you, sir.
Thank you.